Hi guys, Dr. Gillard here. It's GIGU. This is for Thursday, week 9, fall 2020. I'm going to split this up. It's another, this is a 3-hour lecture, supposedly a 3-hour block. So it's got over 100 slides. So let's split this up into 2 pieces. Here we go. And we're going to talk about groin hernias today. And we'll get through inguinal hernias, and we'll get through just in general, and then we'll talk about indirect inguinal hernias and processus vaginalis or persistent processus vaginalis, and we'll stop at direct hernias, and we'll do that in part 2 of the video. So let's just remember what hernias are. This is a really easy to make test question from this, but these are softball. You can't miss questions like this. Which one of the following is not an abdominal wall hernia? These are all abdominal wall hernias. Umbilical hernia, I'm not sure if we're going to get to those this time. I have lectures on YouTube because I want to make sure we get to Crohn's and ulcerative colitis. We have epigastric hernias, which are hernias that occur in the linea, not semilunaris, oh my god, my mind just went blank. Well, it'll come to me. The linea semilunaris is the one that goes between the rectus abdominis and all the flat muscles. Right? There's the rectus abdominis muscle would be in between here, and there's that linea alba is what I was thinking of. Linea semilunaris, and you can get a herniation right between the external oblique, internal oblique, transversus abdominis. Those are the flat muscles, right, or the side muscles. So you can get hernias right in that linea semilunaris, and those are called Spigelian hernias. We're going to talk about indirect inguinal hernias. I don't think we're going to get to femoral hernias, but those these are all abdominal wall hernias. These are groin hernias. Direct and indirect inguinal hernias are groin hernias. We can get hernias from an appendicitis, where the cutting through the abdominal wall leaves a weak spot, and you can get what's called an incisional hernia. And then in the linea alba, that tendon that separates the right from the left abdominal, or the rectus abdominis and the right rectus abdominis is separated by the linea alba. So you can get epigastric hernias up there underneath the xiphoid. You can get suprapubic hernias as well, which is not in here. So make sure you know these if you don't already. But let's focus on groin hernias. We did a couple of these slides last time. But groin, where is the groin? Of course, it's the pubic, or the ASIS, anterior superior iliac spine, to the pubic tubercle. That's where the inguinal ligament runs. It's basically that region right there where your thigh meets your trunk. That's the groin region. And groin hernias is a general term which describes hernias in this region. And groin hernias are still under the giant category of abdominal wall hernias. There's 2 types of groin hernias: inguinal hernias and femoral hernias. So these are all abdominal wall hernias. But now we're under the main category of groin hernias. And then we have inguinal and femoral hernias. On inguinal hernias, there's 2 subdivisions under that. There's the indirect and direct inguinal hernias. These are super high yield board questions, right? These are the most common hernias on the planet, indirect in particular. And femoral hernias are pretty rare, so that's why I have a YouTube video on it, but I'm not going to get to it this time because I had to make room for some other stuff later on. This naming system of groin hernia being basically the main category, and inguinal hernias underneath that, and femoral hernias underneath that. That's not universally accepted. Some surgeons and some authors actually say these groin hernias that's an AKA for indirect inguinal hernias, but Robbins doesn't do that, and so I don't think we should do that either. We're not going to do that. But just for if medical students are watching this or someone else, therapy students, make sure you know what your board book is and what the terminology they use. Yeah. And if you really want to go into the weeds, there's a NIFUS classification system that spine surgeons use where you can classify them even more precisely. All right, let's get to inguinal hernias. This is the big one. If something's going to show up on any type of board, this is the one. This is the most type of abdominal wall hernia, period, is the, actually the indirect inguinal hernia is. But just in general, inguinal hernias are the most common type of abdominal wall hernia. As I said, there's two types of inguinal hernias. There's a direct and indirect. aka for indirect, sometimes it's called a congenital hernia, and a direct inguinal hernia is sometimes called an acquired hernia. So in general, with regard to inguinal hernias, it occurs when, well, it's a hernia. That means something has to push through some type of orifice. So a small bowel herniates through a tissue defect. So that would be a direct hernia. Or there's an embryological hole left over, i.e. the processus vaginalis, which we'll do a tiny bit of embryology here to refresh your minds on that. Actually, I don't think I covered that in embryology. So we'll go over that here in a second. But yeah, so it can be a tissue defect or a weakness, especially seen with getting age, with people aging, or it can be a flat out hole or tube that didn't scar up like it's supposed to be. These inguinal hernias occur in one of two places. You need to know this. So in a fairly muscular region called the inguinal triangle or Hesselbach's triangle, that's a direct inguinal hernia. And then there is a hernia that occurs through the deep inguinal ring, and that would be a indirect inguinal hernia. It's outside of Hesselbach's triangle, and we'll get into that. Just for your anatomy, remember here's one of the rectus abdominis muscles. This is a posterior to anterior view, so we're actually inside the abdominal cavity looking out. And there's that linea semilunaris would be right here, or you could say the lateral part of the rectus abdominis muscle. That's one border of a triangle. Here's the inguinal ligament coming across, and here's the epigastric artery and vein coming across like this, and they form a triangle. Indirect inguinal hernias occur right through this kind of a weak area here. And then direct inguinal hernias, here's the deep inguinal ring, which leads to the inguinal canal. That's where your indirect inguinal hernias occur. So definitely need to know that at the very least. What's the epidemiology? Again, these are in general, inguinal hernia is the most common abdominal wall hernia. 75% of all abdominal wall hernias occur in the groin region. The lifetime risk is about 25% or 27% for men, only 3% for women. Not exactly sure why that is. The thought is that men tend to have more physical jobs, more physically demanding jobs. Inguinal hernia repair is one of the most common surgeries performed in the United States. 20 million inguinal hernia repairs are performed each year. That was based on 2018 research. And here's a little direct inguinal hernia, which is sometimes difficult to tell between a indirect inguinal hernia. We'll try to look at the difference of those, but sometimes you can't tell till you really get in there. The epidemiology, some more, the prevalence for an inguinal hernia in a 75-year-old man. So if you just did a study of, let's say, 1,000 men who are 75 years of age, 45% of them would have a inguinal hernia. So it's almost half of them. But that doesn't mean they're symptomatic. So about 30% of the patients with these inguinal hernias are completely asymptomatic. If they do get hernia repair surgery, 15% reoccurrence rate, which is ridiculously high in my opinion. I mean, disc herniation reoccurrence rate's about maybe 2-3%. So this is quite high, I think. And yep, here's a little guy off to a rough start. He's got an umbilical hernia, and he's got hernias going bilaterally down both sides, right? So could be indirect, could be direct. Let's see, do we know the answer here to this, what the surgery showed? Bilateral inguinal hernias, indirect inguinal hernias. Yeah, so these were indirect inguinal hernias with fluid. You can get peritoneal fluid down here. It's from a persistent processus vaginalis. Sorry, I can't warn you when these gross pictures are coming, but this is, according to the New England Journal of Medicine, this is the world's largest inguinal hernia. A guy had been in to the docs, the surgeons, several times years before this, and they begged him to get the hernia removed, and he refused, and they let it grow and grow and grow. And now he finally came back in because he's disabled. He's got back pain, this thing from carrying this big thing. It's all filled up with fluid. And they can't, it's too dangerous. They can't take it out. Look at the size of the blood vessels that have grown here. So, what are risk factors for having an abdominal or an inguinal hernia, or any hernia for that matter? The groin region in particular is a congenital weak spot in the human. And this weakness comes from evolution, it's believed. We haven't been walking around on two legs for that terribly long, and therefore we still have a weak area in the lower abdominal region. There's also no posterior rectus sheath down there, which makes matters worse. And then this darn processus vaginalis, which is supposed to dry up by the time of birth, sometimes it doesn't. In fact, about 25% of men, it doesn't dry up, and it leaves a communication between the peritoneal cavity and in the bottom of the basically the space around the testes, so it can fill up with fluid, or even intestines if it's big enough. Increased intra-abdominal pressure is definitely a risk factor for any type of hernia. Things like truncal obesity, just having a lot of belly fat, that increases the pressure increases the chance for GERD, we know, but it also increases the chance for most types of hernia. We'll come back to that fat in a minute, because there's an interesting kind of a non-intuitive link between fat and actually protection of some type of hernias. But anything that, in general, that increases the intra-abdominal pressure. In fact, that's probably not a great example to have right there, since we really are talking about inguinal hernias. See if I can remember to fix that 18. What are some examples of intra-abdominal pressure that does increase the risk for inguinal hernia? Cough, COPD. People with COPD are coughing all the time. Chronic obesity, risk for many types of abdominal wall hernias, but not inguinal hernias. That fat's thought to kind of plug up I'm kind of wreck my slide, but the fat's thought to maybe plug up that internal inguinal ring and not kind of blocks intestines from getting down in there. Chronic constipation, maybe people on long-term opioid users. People who have urethral problems that are blocked, maybe from BHP or stenosis or stones, many different types of things. But anytime you have dysuria and you're pushing all the time to go to urinate, just like you're pushing with constipation, that's going to chronically increase your abdominal pressure. Heavy lifting occupations, hobbies, bulimia, throwing up increases pressure, and pregnancy. What about age as a risk? Age is definitely a risk factor. The older you get, the more degenerated and degraded the elastic fibers and the collagen of the deep inguinal ring becomes, and it makes it more stretchy and more amenable to bowel getting sucked down inside there, especially those greater than 7 years of age. And yeah, I said that already. Being male, as we said in the opening, there's good old George of the Jungle, right? You guys, you young people know who George of the Jungle is. It was a cartoon back when I think that was probably in the 70s. I don't remember it back in the 60s. But anyway, being male is a huge risk factor for developing inguinal hernia. 90% of all inguinal hernias, inguinal hernia repairs are actually in male patients. Why the difference? Well, it's thought something about the testes. We'll go through some embryology, but the testes are pulled down through the inguinal canal, and it stretches it out. In females, the ovaries aren't pulled down; they stay up. The only thing that gets pulled down the inguinal canal is just that little skinny round ligament, and that doesn't do anything. So that's the reason that we believe that to be so. There's some inheritance history there, although it's a little shaky. If your mom and dad has had a inguinal hernia, your chances seem to be increased. However, there are some twin studies that didn't, a couple sets of twin studies that didn't demonstrate this. So that might be a little shaky there. Occupation is definitely a risk factor. People do medium to high physical effort jobs like construction. They're definitely at risk. Now here's the weird thing with obesity, like those double fried donuts. They're supposed to be very, very good. But obesity seems to be protective against inguinal hernia, but not the other abdominal wall hernias. And we're not exactly sure why that is, but there's quite a lot of research on that. It's thought maybe that the fat plugs the inguinal canal and just acts as a protective sheath over the inguinal triangle. So we're not 100% sure what it is, but non-obese individuals defined as a body mass index under 25 kilograms per cubic or per square meter have twice the risk of suffering an inguinal hernia. So that's interesting. And you better believe I usually ask that question. I should have more stars on that slide. Marfan's, the connective tissue diseases, also these people are at increased risk for abdominal or from inguinal hernia, especially the direct inguinal hernia. And that's a kind of a interesting fact. So patients with inguinal hernias have been shown to have a increased risk for abdominal or all aortic aneurysms. And it's thought that maybe they do have a undiagnosed connective tissue disorder, but if you do get an inguinal hernia, there is an increased risk for aneurysm. Some more associations. BHP, it's because of the pushing and straining, 3 to 4 fold increase from a normal person of you getting an inguinal hernia. Smoking doesn't seem to have effect. COPD, about a 2.5% risk for getting one of these hernias. How do they present clinically? Well, the patient usually notices a bulge, especially if he's sitting on the toilet. He or she is sitting on the toilet and they're constipated and they push it and they can literally see a bulge come out. And it may pop back in after the kind of Valsalva's act is over. Same with children. They could have a bulge when going to the bathroom and it retracts during all other times. So it can be difficult to catch sometimes. The hernia may or may not extend into the scrotum in boys. The labia majora in girls, it doesn't. They don't have scrotums, but their inguinal canal leads to the labia majora. Differential diagnosis of bumps in the testicle, cancer, right? Especially people your age, people in their 20s, guys in their 20s, increased risk for that's the testicular cancer. Lance Armstrong had that. And we have cryptorchism or cryptorchidism, cryptorch like stork, dism, cryptorch. I always call it cryptorchism, but that's an undescended testicle, and you only have one testicle in your scrotum. And because the opposite side is gone, it makes you look like you have a big bump in your testicle. And when you don't have a hernia at all, but you have an undescended testicle, which increases the chance for that thing becoming cancerous. Lymph nodes can do it, inguinal lymphadenopathy. Hydrocele. can be very tricky. Sometimes, well, without touching it anyway, hydrocele can look just like an intestine herniating down into the scrotum. So hydrocele, definitely. Now let's get into specifically into indirect inguinal hernias. We got to go through this because you're not going to understand an indirect inguinal hernia if you don't know a little embryology here about how the testes descend. Remember that the testes in the embryo, they are way up in the abdominal cavity. They're not down. There's no scrotum at this point. So the first thing that happens is you get a condensation of mesenchymal tissue that forms a cord, and it grows downward from the abdominally located testes. The testes are up about on the posterior abdominal wall about the level of T10. So you have this little cord, like here's the posterior abdominal wall, here's the testes, here's the posterior abdominal wall, and here's the bottom of the abdominal cavity, and there's your legs there. But you get this kind of like if this is Spider-Man, he shoots like a spider web down here, and it sticks right to this place. So now you got this cord running from the bottom, the inferior pole of the testes down to this area, which is going to become the scrotum. And this cord, this spider web, that's called the gubernaculum. The gubernaculum. I do like that. You know I like my embryology. Right? Oh, there's a picture. I could have just drawn the picture. But yeah, it goes around the pubis, and it ends up right here, and this is going to become the scrotum here pretty soon. So the gubernaculum, some call it the genital inguinal ligament, and yeah, that's what it does. And now you're wondering, well, so what good is that going to do? How are we going to get that testes all the way down here? Well, part of the reason is this gubernaculum is going to start shrinking and reeling this testes in over the symphysis pubis here, or the pubic bone, and down here into the scrotum region. And so that's pretty cool. So once this has reeled in the testes, I don't know if I probably forgot to say all that in here, but once this has contracted and got the testes down to here, so now the testes right here where the scrotum is going to be, then something else really weird happens. We get this thing called a processus vaginalis occurs, and it is a outpouching of the peritoneum, and it pushes down, and it starts to form basically the scrotum. And as it pushes down, it takes all these layers with it. So you basically get an outpouching right here of the peritoneum. Right? Still connected to the peritoneal cavity, but as this goes down, this is going to extend down into the scrotum. Let's draw the scrotum here. So this is going to get bigger and bigger. It pulls this with it. So the testes and this processus vaginalis, they go down together to the very bottom of the scrotum. Okay, so it pushes down. As it goes down, it takes all the layers, because this is the abdominal wall here. So the abdominal wall has, and I know it's kind of weirdly formed right now, because you think the abdominal wall is up here, but it actually goes all the way down here in the unborn. And it takes all those layers, the external oblique fascia, the internal oblique, transversalis fascia, takes all those guys with it. Okay, so soon the processus vaginalis and gubernaculum will end all the way up and down at the bottom of the new scrotum. Do I have a picture? Yeah, we can see this happening here. So the processus vaginalis is forming. Gubernaculum is still attached, and the author should have had this testes coming right down with it, because the neuro research shows they go down together, right? And so they're headed down this way. And the gubernaculum should be all the way down here. Gubernaculum is also still contracting and pulling this along. But look at all the abdominal layers it's taken with it. So this gubernaculum, or this processus vaginalis, has all of the abdominal layers, except for one, and we'll look at that in a minute. So descent of the testes, so about week 30, it's usually done by week 32 of fetal growth. And it's a controversial how this works, but arguably the gubernaculum undergoes a shortening and pulls the testes down to the final resting place in the scrotum. The increasing intra-abdominal pressure, because the organs are growing and the intestines are getting bigger, so that increases the intra-abdominal pressure and helps push the testes down there. The key, though, the testes are not pulled through the processus vaginalis, right? The testes are outside of the processus vaginalis. So they're still extraperitoneal. The testes are never intraperitoneal, right? That's a good embryology question, right? This is peritoneum, right? Here's the peritoneal cavity, and this processus vaginalis is an extension of the peritoneal cavity, but the testes are behind that, so they're not part of that. Okay. Let's see. Did I get everything I wanted to get? Yep. So let's see. I think we got that. Testes are not pulled. Yep, that's where we left off. And there's just a further example. Now we got the testes. The gubernaculum is really short. It's shortened up this much. The processus vaginalis and the testes are all the way bottom. The scrotum has grown out here. We've taken all these abdominal layers with us, and we still have, there's peritoneal fluid here, peritoneal fluid here. This is a communication to the peritoneal cavity here. Okay, now goodbye to the processus vaginalis. This happens in 75% of men. So once the testes are in place, the processus vaginali, processes, or the proximal portion and the middle portion disintegrate, and they dry up into a fibrous thin cord. And that's good, right? Because you don't want your peritoneal cavity down here. It's too easy to get this blocked off and get some type of a infection down here. You want to get rid of this. So from about here to here, you're going to get rid of that thing. You're going to scar it up into a little bit of a cord, but not this. All right, this is going to be kind of wrap around the testes. It never engulfs it completely, but this is the processus vaginalis cavity, you could say, and it's going to surround the testes. Remember the tunica vaginalis, parietal and visceral layers? This becomes the visceral. This is the parietal. This will become the visceral layer of the tunica vaginalis, and that's the cavity for the tunica vaginalis, which has a little fluid inside of it, if you remember back from your gross 2 anatomy. All right, so let's see. The distal portion spreads out to cover the front and sides of the testes, we said, and it creates really a peritoneal cavity kind of isolated from the main peritoneal cavity, right? Because that was peritoneum. Now we got rid of this, we fused this all together so that the communication is now gone, but nevertheless this was peritoneal cavity, and so some people call that a testicular cavity now, or testicular peritoneal cavity. Right, distal portion morphs into 2 serous membranes, as I just said, the parietal tunica vaginalis, the visceral tunica vaginalis, and then the cavity from the tunica vaginalis. And we studied that in gross 2 anatomy. And here's a nice little picture of the, this was our processus vaginalis, but now it's scarring, it's shutting right here, but not down here. This is turned into a serous membrane. So it's got the tunica vaginalis, or the visceral layer of tunica vaginalis, parietal layer, tunica vaginalis, and the cavity of tunica vaginalis. And this would wrap around the backside. It doesn't completely surround, like the epididymis, it doesn't surround that. But it kind of wraps, like hot dog buns, the testes, is what I'm trying to say. But this is still an open cavity. This is normally not. Right, just another picture showing the kind of the remnants of the processus, the proximal and the middle portions of the processus vaginalis, but not down here. And the distal processus vaginalis has formed a cavity, and there's fluid in this cavity. And there's our parietal and our visceral layer of tunica vaginalis. This has become, and that's the cavity for tunica vaginalis. Right? If you get kicked in the private parts and you're a guy and you injure your testes, you can get blood into this cavity and you can get a compartment syndrome. Right? Your testicles can swell up really big, and that's because of fluid accumulated in here. Right? And we're going to learn next time about how this is drained. This has a lymphatic system. It's like an interstitial fluid here. It has to be drained because we have serous cells all around here secreting fluid. And there's a lymph system draining that fluid off. So as long as you drain off the fluid and don't over-secrete, that's great. If something goes wrong with the lymph system or you over-secrete this fluid, you can start getting swelling of the testicles. And if this never closed and was wide open, you can literally get peritoneal fluid filling this up as well. So those are both types of swelling of the testicle, or a hydrocele, those are called. Got ahead of my slides, though. We'll get to that tomorrow. Inguinal canal and spinal cord layers. So the inguinal canal and the spermatic cord were created embryologically via the descent of all those players, the gubernaculum, processus, vaginalis, and the testes, and they pulled right through the abdominal wall, and they took all those layers with them. And so you should know the layers of the spermatic cord. So we have external spermatic fascia, cremasteric fascia, internal spermatic fascia, and you know who these were. So the external spermatic fascia, that was external oblique aponeurosa. Cremasteric, internal oblique aponeurosa. Internal spermatic fascia was transversalis fascia. Transverse abdominis doesn't get to play in this little scenario. Here's a little cartoon. The author left off the preperitoneal fat layer, but other than that, I mean, we could have drawn another preperitoneal fat layer right here, because there's a fatty layer. The next picture has it. But other than that, they got it. But you can see the testes. Testes is going to go through a defect here. Well, there's the deep inguinal ring. But you can see how the testes and the processus vaginalis have taken all these layers with it. So the spermatic cord is just basically an outpouching of the entire abdominal wall. The inferior, anterior abdominal wall is the so-called spermatic cord. And then you have all this stuff inside. There's the testes. Gubernaculum would be the remnants of that. It's probably gone by now, and you can see the distal part of the processus vaginalis is still open, so we have a cavity here. But at this point, we don't call it processus vaginalis anymore. We rename it. So that's the tunica vaginalis parietal layer, tunica vaginalis visceral layer. Cavity for the tunica vaginalis is right here. It's always filled with fluid. This would be hot dog bunning the testicle here. But you can see all these layers are with us. Now the parietal peritoneum was open. Now it's not. It's fused. So that there's no longer a communication in 75% of guys. But look at all these other layers that go with it. So let's go to the next correct picture. We'll look at this. So this is the layer. Here's the spermatic cord right here. There's the deep inguinal ring. And now we can see all the layers. So here's the parietal peritoneum right here. That doesn't go. That's sealed off. But everything else goes. So there's preperitoneal fat, or this is what I call this fatty layer. Remember, this is the deep fascia, transversalis fascia, preperitoneal fat, and parietal peritoneum. These are the deep fascia. We actually saw them in Gross 2 anatomy. I used to stick pins in there and drive you guys crazy with those pins because they're hard to tell apart. But the preperitoneal fat and the transversalis fascia, look, they go all the way down. You can follow them all the way down. And yep, they're there. They change names, but they are still there. They go through this deep inguinal ring. The transversus abdominis muscle doesn't. It stops, dead ends right here at the deep inguinal ring. But everything else goes. There's the internal oblique. You can see that goes all the way down. And you can see the external oblique aponeurosa goes all the way down as well. Right? And then they're still the same things. They just change names. So the external oblique turns into external spermatic fascia. The next layer down, the internal oblique turns into cremasteric fascia. The next layer down, now we skip transversus abdominis, doesn't play the game, but transversalis fascia does. This is the transversalis fascia layer, and that's called cremasteric fascia. Then we have the, let's see, did I get messed up? External oblique turns into external spermatic fascia. Internal oblique cremasteric fascia, I messed up. This internal spermatic fascia came from transversalis fascia. And then all this yellow stuff, that's preperitoneal fat layer. Okay, got it? Where's the third layer? There's 3 layers of the deep fascia. That the very deepest one is parietal peritoneum. Where is it? It doesn't go, right? It was processus vaginalis. There's part of it used to be right there, but it dried away. All right, see how that works? Now we have a nice pampiniform plexus, testicular artery right here. Keep that in mind. We're going to talk about that. Can you imagine if a hernia comes down here and squishes this and squishes all this blood? You can get an infarct of the testicle or ischemia of the testicle with that. Anyway, there's Hasselbeck's triangle again. We already talked about that. There's the deep inguinal ring. Superficial inguinal ring lives at the bottom of this triangle, but outside of this. Right? This is a solid tissue, so you can't see that. I just put it in dotted lines so to show you where it is. But all right, so this persistent processus vaginalis occurs when the processus vaginalis fails. And by the way, sometimes this is called the vaginal process. It's another AKA for this. It fails to degenerate away like it's supposed to, and it stays wide open. And that ain't a good thing, because now the peritoneal cavity actually runs all the way down into the scrotum, and that's not good, right? You have peritoneal fluid running down there. And it could be a partial, so you could have just a little bit of it open, or it could be wide open, and that makes all the difference in the world. So here's that same little cartoon where the processus vaginalis is still wide open, yet the testes are formed, and that's no good. This should be scarred shut, because now we have all this peritoneal fluid could be leaking right down in here and causing some swelling in the testicles. And if intestines get up in here, you can get intestines pulled down in through here, right? And that's an indirect inguinal hernia, when the intestines go down a persistent processus vaginalis. All right. If the processus vaginalis fails to obliterate everything I just said, then you have a natural opening between the scrotum and the peritoneal cavity. That's no good, right? Peritoneal fluid will collect there, and everything I just said. If you're a female, what's the deal with female? They don't have testes. Yeah, but they still have a processus vaginalis, and that can stay open in 25% of them as well. And they can get fluid, peritoneal fluid, draining down to the bottom of that persistent processus vaginalis. But remember, that goes to the labia minora. So they're just going to be getting some swelling down there by the I guess the superior anterior part of the labia majora, kind of where the mons pubis is. I'll show you a picture of that in a minute. And we already said, well, here's just some more different source. About 26% of adults have one, and this is according to Standring, which is a board book. And of that 26%, 20% of them, so about a quarter of them, will develop at least a hydrocele. So that's swelling around in the scrotum or in the labia majora, and or a direct inguinal hernia where they get intestines sucked down in there. So that's not good. If it's present on one side, it's usually present on the other. About 85% chance of having bilateral patent process vaginalis. Only 11% actually get a hernia, though, who have doubles. Of that 85%, 11% of them get bilateral inguinal hernias. Hernia or hydrocele. So if the processus vaginalis, if the tube is really small, you're not going to be able to get intestine down there. So, but you still can get peritoneal fluid, and that's that fluid collection around the scrotum or the labia majora. That's called a hydrocele. If it's a large processus vaginalis, you can get a hernia down there. You'll get hydrocele as well. You get some fluid down there, but the intestines will get stuck, and that's a direct or indirect inguinal hernia. All right, so back to the indirect inguinal hernia. Again, that is the most common type of groin hernia. It's also the most common type of abdominal wall hernia. 75% of the groin hernias are of this type. 25% are direct inguinal hernias. It occurs when small bowel gets into the deep inguinal ring and starts going down the inguinal canal. But it stays within the processus vaginalis, right? It just doesn't go outside of that. It can't go outside of that. Okay, we talked about that already. Anatomically speaking, the hernia sac is inside of the inguinal canal. Yeah, how come? I thought it was inside the processus vaginalis. Yeah, but the processus vaginalis is inside the inguinal canal. And it's also the processus vaginalis is inside the spermatic cord. So these indirect hernias go right through the spermatic cord itself, go through the inguinal canal, through the deep inguinal ring, through the superficial inguinal ring, but it's still inside the processus vaginalis. Okay, and it could end up in the scrotum, as we said. What are the layers of the hernia sac on someone with an indirect inguinal hernia? Well, it's really only the peritoneal layers, because the intestine has visceral peritoneum around it, and you're now taking parietal peritoneum around it because you're going through the processus vaginalis. So those are really the only two layers around it. All the other layers are there, but those are part of the inguinal canal and spermatic cord anyway. All right, there's just another cartoon showing you hernia. So if this, I forgot I was going to draw. I always say this every quarter. I'm going to make this a piece of intestine next time. And the intestine has visceral peritoneum, right? So that would be herniating down, and it herniates into this sac. I mean, it would be all the way down here probably, or maybe not. Maybe it hasn't made it down there. But it herniates into the sac, and the sac is really lined with parietal peritoneum, right? And then the sac is inside of all the other layers, but those are already there, so that's not counted in the sac. So here's an indirect hernia on the right side in this little guy. And unfortunately, intestines have made it all the way down here. Looks like you might have a little swelling on the left, maybe some fluid on that one, hard to tell. Here's another nice drawing of this where the intestine has went right through, all the way through the inguinal canal, and it's inside a processus vaginalis. So this is parietal peritoneum of the processus vaginalis here. It's still got all the other layers of the spermatic cord and inguinal canal around it. But yeah, that's a nice picture. You can see how it's passed through all these layers. What about females? We already said they can get a bump right into the mons pubis here. So we're getting into the mons pubis, and the vulva would be down here. Labia majoris would be, it didn't even make it down here. Labia majoris would probably be right about here. You can see the hair's on the mons pubis normally. And so there it is right there. But I mean, there's no scrotum for it to go into, right? So the farthest it can go is into the labia majora, the kind of the superior anterior part of it. All right, and if they have females have a small processus vaginalis, that fluid can go through the persistent processus vaginalis. In females, that actually has a name. And this is in Standring, and that's a board book. It's called the canal of Nuck. Canal of Nuck. What is that? It's just a persistent or an open processus vaginalis. And if they have a really large processus vaginalis, they can get intestines down there, the uterus in some cases, fallopian tubes. So a surgeon commented that they never know what they're going to find when they go and open one of these things up to kind of decompress it. Now, Standring is the only book I saw on this, but it's a board book, so I kept this in here. The concept of complete and direct inguinal hernia versus incomplete. So if the hernia sac ends up all the way in the scrotum, some authors like Standring, and that's the big, thick Gray's Anatomy, kind of the Bible of all anatomy books. He or she, it's a she calls that a complete congenital indirect inguinal hernia, or just a complete inguinal hernia. If it doesn't, if it stays up higher and doesn't make it all the way into the scrotum, then it's an incomplete congenital indirect inguinal hernia. All right, so there's a good example. Well, you tell me, is that a complete or incomplete? Well, it says incomplete. It must be incomplete. And it is. It doesn't. It's not making it into the testes at all. It's stuck right there. This would be pretty hard to differentiate from a direct inguinal hernia as well. Now these can get strangulated. That's the problem with these things. Because your intestines is pushing through that little tiny deep inguinal ring, the walls of the intestine can be compressed enough where the circulatory system is destroyed, and the tissue will become ischemic, and it can rupture. It's inside the peritoneal cavity still. So you can get septicemia from this, peritonitis leading to septicemia from this. So these are not good. These strangulated indirect inguinal hernias, that is the most common surgical emergency worldwide because of perforation, peritonitis, and septicemia, and is one of the most common causes of intestinal obstruction in all ages, are these indirect inguinal hernias. Testicular ischemia can happen as well if you get an indirect inguinal hernia that doesn't go all the way down, or maybe it goes all the way down, but we have the pampiniform plexus and the testicular artery. If you get a big piece of intestine, right, coming down here, it can squish this and cut off the blood supply to your testicle, and you can get that's not good, right? You can become sterile. You can lose your testicle. And here's a 2012 journal article about a 48-year-old male who had a right-sided indirect inguinal hernia, and sure enough, it cut off the blood supply to his testicle, and he got horrible pain from testicular ischemia. So it definitely, just to show you, it does happen. And then the bowel can strangulate. We kind of already said that, but on what could we see that? Do we have any tools? A chiropractor have any tools we could see this? You could take a soft tissue film of the abdomen and look for bowel gas, because we know that obstruction stops the flow of fecal material through the intestine, and if that flow is stopped, the bacteria, I mean, that's like a party for them. They breed and breed and breed and release methane gas, and you start blowing up, and you can see that on radiographs. So here's a, what was he, 56-year-old man, has a lump he noticed in his right groin, and he's got horrible abdominal pain and signs of obstruction, or a small bowel obstruction. You take an x-ray, and sure enough, there's kind of a stat coin appearance we're starting, and we got a lot of gas building up. That was his x-ray. And then at the time of surgery, I think we've looked at this before, but this is the actual picture. You could see after they released the inguinal ring, that's what his intestine looked like. That was trapped in the inguinal ring. And it's not only inflamed, it's become gangrenous, right? Developed gangrene. So this is going to be cut. The doc will cut it from here and here, and he'll sew these two ends together, and take this, all goes to the lab for testing, but that's ruined. All right, everything I just said. All right, so let's stop it there on slide 70. I think I've had enough, and I'm pretty far ahead, aren't I? We're finishing up week 9. It's actually, we're just starting week 8, so I'm trying to stay a week ahead of you guys, because some of you are actually right on my tail too. You guys are chasing me. You like to watch these ahead of time, and that's the whole reason I'm doing this for you. You guys who like to stay ahead. All right, see you later.